Hello, good evening, everybody. I hope you had a wonderful day. Hope you can hear me. Just confirm that I'm audible enough. Am I? You can hear me?
Yes, yes, Dr. Good evening.
Thank you. It is good to see you once to take the match we can today, and I hope we are going to learn a lot from today. So I want us to just start so that we maximize on time. As I promised that I don't want to take much of your time. If it is possible, we can be finishing up latest 8:15, so that you have time to go do your other things. And I also say that in case maybe there are areas that you will not be able to understand for now, we'll have recordings and slides so that you can always have time to go through them. And also, we'll not be disbanding the group. We'll always have time to interact. So yesterday we had looked at quite a lot, and I am trusting that today, with the help of God, we'll be able to really finish up the session. So we had looked at the background of cancer cachexia, how it comes in the pathophysiology. We were also able to be able to look at the aspect of the um, the kind of metabolic changes to cancer, and we started something few on looking at the aspect of cytokinins. So before I proceed to from where I left yesterday, I would like to do a recap or based on the question that our colleague Chetna had asked, that we repeat to understand this Cori cycle. So you remember we had said that carbohydrate is the major source of energy for the body. And in scenarios where we have cancer cachexia and the body is not able to have adequate from the diet, it resorts to physiological changes through the mechanism of lipolysis, gluconeogenesis, and glycolysis. So basically, Cori cycle is one of those mechanisms by which the body uses to stay physiologically stable despite the onset of cancer. So what this Cori cycle basically means is that we have the blood in the circulation. So this is just the blood vessel, and inside of it is a blood circulation. So inside of the blood circulation, we have nutrients which are transported to the cells. And the one of the key glucose nutrient is the glucose. So what happens is that when there is no adequate glucose in the blood circulation to the cells, what happens is that the muscles will be broken down. Okay, so once the muscles will be broken down, the byproduct of that through anaerobic process is what we have, what we call pyruvate. Then pyruvate will be converted to lactate, and then lactate goes inside the blood circulation. And again, the same process, the lactate will be absorbed into the same process that in the liver also, when we have the pyruvate, which is converted into glucose, and then it goes to the circulation. So these are just a cycle by which the body is able to replenish the limited glucose due to infection, or may that is like cancer, and also when we don't have adequate dietary intake. So Chetna, Cori cycle and Krebs cycle are one of the mechanisms by which the body uses to 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 make sure that they compensate the aspect of the aspect. I have logged in. I'm not seeing anyone here. Okay, just give me a few minutes. I saw somebody here. This is the link. I don't know which link they're using. So let's continue. So basically, that's the mechanism by which the body make use of the liver and the muscles to be able to provide adequate glucose within the circulation system, especially during acute starvation and when we are not able to eat adequately. Chetna, is that okay? Has that been well explained for you?
Thanks a lot.
Okay, okay. Thank you, thank you, thank you. All right. So, having said that, I think now we can move on to the next part. So today I just want us to these ones we had covered yesterday, so I don't want to take much time. Today I want us to look at something cytokinins. I don't know if we covered much about it, but let's just have a recap about it very well so that we get to understand what it means and in relation to cancer cachexia. So remember yesterday we were entirely looking at dietary and starvation in relations to cancer cachexia. So today I want us to focus on the aspect of cytokinins and what they play in terms of cancer cachexia. So, as I had explained yesterday, cytokinins are chemical agents that are produced by the tumor to the circulation. So, these chemical components have the capability of increasing the metabolism of the patient, and therefore they also have the ability to cause what we call systemic inflammatory response syndrome. What systemic inflammatory response syndrome means is that when we have an organ which is foreign to the body tends to react to that kind of property. So, for example, if you are sick with the bacterial infection, what the body will do, the body will try to do what to fight that bacteria by releasing antibody against the bacteria itself. So the apologies. Cytokinins are one of those chemical components that are produced by the tumor that has the capability of increasing the metabolic of metabolism of the body, and through that they will also be leading to the aspect of cancer cachexia, because now there will be an ongoing inflammatory process. So, recent research work has focused on the role of cytokinins, which through broad physiological actions produce metabolic changes and wasting in tumor-bearing host that are similar but are not identical to changes seen in patients with sepsis and inflammation. So, what happens is that the tumor has capability of producing these chemicals into the circulation, and therefore the body is trying to react to them. So cytokinins are soluble proteins. This is one thing that you need to learn by definition. They are protein in nature, so they are soluble in proteins. They are peptides. That is something also you need to know. And also they are glycoproteins. So that is what they do. So they are produced predominantly by immune cells. So the immune cells of the body are they able to produce these cytokinins in terms of to interact with the tumor chemicals that mediate interaction between cells and regulate cellular and tissue function. So these substances are found in the blood. So we find them in the blood, mostly cytokinins. They are also found in ascites. Ascites is just the fluid that has been able to escape the abdominal cavity. And then also we have pleural effusion. Pleural effusion is basically the fluid that has escaped when we have fluid escaping from the lungs. So that is where we find the cytokinins to be more present and are believed to play a major role in biological response that lead to the wasting seen in cancer cachexia. So if you are managing cancer cachexia and you only rely on diet alone, then you might be able to miss a lot, because it is important to understand that cancer cachexia, as we talked yesterday, it is a multifactorial. So cytokinase is one of the things that the substances that have been studied and found to have a severe role, a major role in the biological responses that lead to wasting that is seen in cancer cachexia. And I think I was able to explain this using this diagram, that when we have tumor, then the body tends to produce the cytokinins, and these ones are going to have impact on the central nervous system, on the muscles, on the liver metabolism changes, and also on the fat. So that is how they basically work. So there are chemicals that are produced in response to cancer tumors. Some of the examples of specific cytokinins that are related to cancer cachexia, one of them is what we call tumor necrosis factor. or TNF. It is in two forms. It can be an alpha or a beta. So this is one of them. Then we have also cachectin. We have interleukin 1, interleukin 6, and interferon Y. So these are just an examples of those chemical protein like chemicals that are produced secondary to tumor itself. So they have been studied and found that they have also relations in terms of cancer cachexia. So basically what they do is that they increase the metabolic the component of the body, and through that you find that patients are able to have wasting syndrome going on. Are we together up to that point?
Excuse me, I can't see your screen.
Really? My God.
Yeah,
It,
I think I have
it,
done something and then I can't see the screen.
uh-huh. Other people, you are seeing my screen? What you can do, Lynn, is just leave and rejoin. It could be network issues.
Okay.
Yeah.
Yeah.
Other people, are you able to see the screen?
Yes, we are able to see your screen.
Okay, great. So let her rejoin again, because it could, when your network is unstable, sometimes you might not be able to see the screen, especially when you're using your phone. Yeah, so that is all about cytokinin. So it is important to understand this concept, because again, it will help you. So now, how do we counteract the effect
Hello,
of cytokinin?
I'm seeing your screen appearing in a homepage.
Yes, even me.
Oh, okay. Pole. Let me see what has just happened. All right, let me see. How do I stop sharing? It's not supposed to appear in the homepage. What have I done today? My presentation. So give me a few minutes. I see if I can stop my presentation. How do I stop the presentation? I hope I'm not. Oh, okay. Now I see. How about now?
I can.
Yeah, it is okay now.
Thank you.
Okay. Nice. Thanks, guys. I think I've shared the entire screen. That was not right. Sorry about that. So good. So now we can move on. Thank you for that. Lynn, I hope you're now okay.
Yeah,
Lynn?
I'm okay now.
Great. Now, so I was explaining, how do we now counteract the effect of cytokinins into the cancer cell? This is where now the antioxidants come in. Remember, cytokinins are part of free radicals that are just free radicals. We are talking about unoxidized ions that are flowing within the cells. So the reason why you find most of the cancer cells multiplying very fast is because we have an oxidized ion which are freely moving within the cells and help to destroy the normal cells. So when they are unoxidized, then that is when they cause harm. So what happens to assist that is the aspect of providing antioxidants component to boost the immune system of the body. And now the antioxidants like zinc sulfate, zinc is an antioxidant. We have vitamin A, vitamin C. Those are all classified as antioxidants. So what they do, they now oxidize these free radicals, and then they make it stable. I want to give you a scenario. During COVID, many patients were being put on vitamin C. Many people were not able to explain, as physicians were just prescribing vitamin C and vitamin D, if I'm not wrong, but there was no clear, they were just saying is to boost immunity. But now the concept of boosting that immunity basically means COVID is a systemic inflammatory response disease. So what it does is that it increases the C-reactive protein, and it allows the free radicals, which are unoxidized ions, to destroy more cells, and that's why you find there's a severe infection. So what antioxidants does, like vitamin C that was being prescribed, is just to oxidize those free radicals, and then after that they stabilize the body immune system. Are you getting that? Are you getting the concept of?
Yes.
Yes, this is very important for us to learn, because how the body cells get destroyed very fast is because we have free ions that are within the cells and they destroy the normal cells. So what happens? They need to be stabilized, and through antioxidants are able to stabilize them by oxidizing them. Therefore, they become stable ions. So they'll not be able to have ability to destroy the cells. So that is what can be done to support cancer patients who we anticipate. Of course, scientifically, we still have researches ongoing to show the role of antioxidants in terms of cancer care. But now it doesn't add harm when you add antioxidants to the diet of the patient. But now more studies are being investigated on that part. Number two, you also need to increase more proteins for cancer patients, especially when in acute phase. So when you increase the protein intake, then remember these cytokinins are in form of protein. So you'll have a balanced nitrogen balance, and therefore this will be able to fight the body immune system. So I hope that is well understood. Now, let's move on to another component also that has been studied and linked to cause cancer cachexia. That is the role of hormones. So abnormalities in body's hormones are also believed to be associated with cancer cachexia, and they include increased cortisol. Cortisol is one of the growth hormones. We have decreased insulin resistant, and decreased testosterone. So all these have had an impact in terms of cancer cachexia. So hormones also play a role in causing the aspect of cancer cachexia. So we had looked at dietary, we had looked at cytokinins, and therefore we are also looking at the hormone role in terms of the cancer cachexia. So when we have this abnormality, for instance, we have increased cortisol hormone. So when we have increased cortisol hormone, it means that the body is in a fight and flight situation where you'll find there is a hypermetabolism always. So that can cause issues with cancer cachexia because the body will require more energy. So there will be increased process of glycolysis, increased process of gluconeogenesis, increased process of lipolysis when we have increased cortisol. And that's why you find people gaining weight, even if they are not, you find somebody who is in a diet management for weight control, but still they gain weight. Have you seen those scenarios? Lydia and Simiyu?
Yes, Mr. Kind, I have seen that. Like people are stressed, but still they are gaining weight.
Exactly. That is the aspect of increased cortisol hormone. They sleep late. They are stressed. Yeah. They don't do exercise. So with that kind of lifestyle, it is hard to lose weight, even if they follow diet strictly. So you need also to look at lifestyle changes. There's something called circadian rhythm. If the moment they interfere with circadian rhythm, then basically they means that their weight will always be unstable. For instance, it is advised that you should at least by latest by 10, you should be done with you should start preparing to sleep. But people sleep at as late as, okay, of course, I'm also a victim of that, as late as almost 11:30, 12, and then they wake up early at 5, 4, meaning they don't have adequate sleep. And again, majority are also addicted to the phones, so their lights are always on. So melatonin hormone, which is responsible for sleep, will always go down. Kadomi Mtembe, I know you are a victim on this. So with that kind of lifestyle, definitely you'll have increased fat accumulation, and that will definitely lead to increased weight gain and risk of cardiometabolic conditions. It is not for my class today. One day I'll be able to take you through that aspect. So we've looked at the hormones. So let's look at some of the stages of cancer cachexia. This is very important so that we understand how the cancer cachexia stages occur. So at present, there are no specific biomarkers for early stage cachexia identification. So staging is determined according to the clinical manifestation and characteristics of the patient. So we don't have a clear uh, guidelines on how the stage happens. But now the clinical presentation is one of the things that we can look into. So the first one is called the refractory cachexia phase. and is determined by the patient's underlying disease and overall condition. Diagnosis of this stage requires a low World Health Organization performance status score and a survival period of less than 3 months. The focus of the treatment for refractory cachexia moved from aiming to cure and control to maintaining the patient's quality of life. This type of grading system can provide patients with more suitable treatment option at all stages of disease development and allows for targeted research and treatment for each stage. So refractory is one of the key things that we looked into when we are talking about cancer cachexia. Just wanted to explain it very well. Just give me a few minutes. Where is that? Just want to show you something on refractory cachexia. Allow me to stop sharing so I can share some. You occasionally sleep at 1. Hey, you need to change. You need really to change. We need to have a talk, and you'll pay me for this. I need to be your nutritionist. All right, so let me explain stages of cancer cachexia using this slide. I hope you can see my slide. This is much better. Are you able to see what I'm presenting? Great. Thank you. Thank you. Now, so we are explaining stages of cancer cachexia syndrome. So there are usually 3 stages of cancer cachexia syndrome. The first stage is called what we call pre-cachexia. The second one is cachexia, and the last one is refractory cachexia. So I've started explaining refractory, but I felt like I should go backwards. So when we are talking about refractory cachexia, it is characterized by weight loss of less than 5%, anorexia, that is loss of appetite, and metabolic changes. So what it means that if, for example, a patient comes to you, they were initially they were 60 kg, for example, and then they have lost 5% of their weight. That means they were 60 and they have come to you, and now their weight is 57, for example. 5% of 60 is around 60, 57, 3 kg loss in the last 3 to 6 months. In the last 3 to 6 months. So you've lost less than 5% of weight in the last 3 to 6 months. And this is an intentional weight loss. This patient was not in weight control program. All right. So number 2 is that the patient will have anorexia, loss of appetite, and then they have metabolic changes. So metabolic changes are the ones we've already covered previously. So what will happen to this patient? What intervention you need to do is nutritional counseling. You can provide fortified food, oral nutritional supplement, consider inclusion of anti-inflammatory ingredients. So anti-inflammatory ingredients are omega-3 and omega-6. So these are the ones you can provide, and also the free radicals. The antioxidants you can provide into their diet. Are we together? So that is the pre-cachexia phase. So you may remember yesterday when we had asked a question of if cancer cachexia can be reversed, and majority of you said yes. Yeah, so this at the pre-cachexia phase, we can reverse it. So if a patient comes to you and they told you that last time they had weighed themselves, they were 60 kg, and by the time you are seeing them, they are 59. That means they have lost close to 5%. You can even do calculations. You ask them, what was your last weight? They'll tell you, I was 70 kg. And then you say, now step on the weighing scale. You do the weight, you find that their weight is, let's say, 67. Okay? It doesn't matter whether they were obese, whether they were overweight, or whether they were wasted. Any weight loss less than 5% of the normal weight within the period of 3 to 6 months, that should be a warning signs that this patient is started getting into a precachexia phase. So if you get that patient to be losing weight and now you need to support them, all you need to do is, first of all, do nutritional counseling. And of course, we'll look at nutritional counseling in details. You need to provide better nutritional counseling, looking at the entire food groups, the frequency of eating, the type of food they need to take, the sleeping time, that is very important also. If you need to provide them with appetite boosters, you need to, and all that. Then don't just leave them like that. Provide them with oral nutritional supplement, whether their weight is okay or not, because these patients are not taking enough. They are already having anorexia. Now, what are the ways of determining metabolic changes? You can send them to the lab to do the CRP. If the CRP is elevated, then that means that they are having metabolic disorders. Mary Mwangi, are we together on that, up to that point?
Yes, we are.
Great. So that is scenario number 1. We are talking about pre-cachexia. The second stage of cancer cachexia is now the cachexia itself. So cachexia is characterized by weight loss of more than 5% or a BMI which is less than 20 kg per meter square, with weight loss more than 2%, or a sarcopenia with weight loss more than 2%. I'll be able to explain all this, so you don't have to worry. We'll define what sarcopenia is. So case study number 2, we are looking at a patient who has come to your clinic, or you are seeing them in the hospital for the first time. They have been diagnosed by cancer, despite the stage in which they have been diagnosed. And then when you are taking the history, anthropometric history, they told you they were 70%, they were 70 kg in the last 3 to 6 months. But now when you do their assessment, you find that their weight is now 65%. So 65%, it means that they have lost more than 5% of their weight. For instance, if they are 65, it will be 65 divided by 70 times 100. So that you'll find, have I gotten it right? 65, that is their current weight, divided by 70, you get that, times 100. No, that one is not giving me what I want. No, sorry, it will be the difference. 5 divided by 65 times 100. Yeah, that is around 8% weight loss. So if there were 70 kg in the last 3 to 6 months, and then when you are seeing them for the first time, you find them to be 65 and you do the percentage weight loss, you'll get percentage weight loss to be around 8%. What that means, they are already lost more than 5% of weight loss. That is scenario number 1. If they can't remember, if now the next criteria is a BMI which is less than 20 kg per meter square with weight loss more than 2%. So for example, their BMI is, you find their BMI to be 19%, and 19 kg per meter square. And then they told you in the last 6 months, they were 70 kg. And then when you do their weight, you find that they are now 68. So it will be 2 divided by 68. So they have lost like 2 kg. And then you multiply that by 100. You'll find that they are close to 2. They have lost like 2%, more than 2%, almost 3. So that is another criteria of classifying them classifying them as those with cancer cachexia, with now cachexia itself. So now, having looked at that, now the second thing that will determine we'll be looking at is the aspect of what we call the sarcopenia. So I need to give you the definition what sarcopenia means, and then now we continue from there. I hope you are following and it is making sense for you. It is important that we really learn this so well. If you have questions, you can stop me and then we learn. So what is the definition of sarcopenia? I want to take a little bit of time on this so that we learn a lot from this from today. So sarcopenia is a low lean body mass, mostly muscle. Fatigue is common, strength may be lessened, and physical function limited. So what sarcopenia basically means, if you have a bioimpedance body analyzer, it is good to see the muscle, the muscle mass when you do the what you call body composition. But if you are not able to have body composition machine with you, it is easy to do muscle strength. What you just tell the patient is to greet you with their right hand, and they try to squeeze your hand tightly. If there is a strength in their muscles, then that is okay. But if they try to squeeze you, but they are weak, they are not able to press your hand tightly, then that tells you that their muscles have started wasting. They have lost muscle strength. That is basically what sarcopenia means. It can also be occurring for obese patients, and this is why I was very categorical that whether the patient is obese or not, you need also to consider them. So as a functionality is lost, patients with cancer may no longer be able to live independently, and they often report lower quality of life. So if we do something we call ECOG score, you'll find the ECOG score have started dropping down. ECOG score is basically a parameter that we use to check the functionality status of cancer patients. It seems that I'm teaching you so many things at a go. Am I confusing you? I don't want to really go deeper.
It's really flowing.
Yeah, okay. Penina, how are you doing?
I'm doing well. I'm following.
Yeah, please let me not confuse you too much. Lynn Odero, I'd like to get it from you.
Could you spell, it's called ECOF, the score?
ECOG score. So it's ECOG, ECOG. It's the European Commission on something on cancer. Eastern Congress something. I'll give you the full meaning in a moment. I'm used to call it ECOG until I forget the full definition. So what we are talking about is this, that when you meet a patient in your clinic or where you practice or in the ward, this patient has been admitted with a cancer case. You are doing your anthropometric measurement, and they are able to tell you that in the last 3 months or 6 months, they were 70 kg, and then when you do your weight, you find their weight to be around 68 kg. Then when you do the BMI, when you correlate the weight versus height, you find it to be the BMI is less than 20 kg per meter square. Then you tell them you're doing functionality test where to either greet you and or sometimes they can tell them to hold your hand and then they try to move you closer or push you away. If they don't have that muscle strength, then they are already experiencing what we call sarcopenia. Now, for obese patients, sarcopenic obesity is also common. So it's a low lean body mass in obese individuals. In such patients, clinicians frequently overlook muscle loss due to the presence of excess fat and extracellular water. In fact, the presence of sarcopenic obesity is an important predictor of advanced outcome, which can be further worsened by surgical interventions. So I need you to be very careful. If you do a BMI of a patient and you find that they are obese and they have cancer, please don't assume that those patients are okay, or don't start thinking of helping them to drop the weight. No, 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 no. One thing that needs to come at the back of your mind that this patient could be having sarcopenic obesity, and this is a significant sign of cancer cachexia. So this beats the narrative that even that cancer cachexia only affect the lean body mass, but it is also even present for patients with excess fat and extracellular water. Remember the definition of cancer cachexia? We said it is a muscle wasting with or without fat loss. So it is important for us to note that. So I wanted just to explain what sarcopenia means and sarcopenic obesity in relations to cancer cachexia. I don't want to lose you. We are looking at the stages of cancer of cancer cachexia, and we've looked at stage 1, which we called the pre-cachexia. Now we are looking at the cachexia stage. And in cachexia stage, we say that this patient has either more than 5% weight loss in the last 3 to 6 months, or they have a BMI less than 20 kg with or without 2% weight loss. More than 2% weight loss, or sarcopenia with weight loss which is less than more than 2%. So in sarcopenia, you don't need even to do the BMI. The moment their muscle strength is low and they have reported their weight loss more than 2% in the last 2 to 3 months, 3 to 6 months, then those patients classify to be at cachexia phase. So what do you do as a nutritionist or a dietitian? These are the patients you will put on oral nutrition supplement, quite high intensive or enteral feeds with adequate energy and protein. So these are the patients, if possible, you can either, if they are critically ill, these are patients you can insert NG tube for feeding. Consider inclusion of anti-inflammatory ingredients. So anti-inflammatory ingredients, we are talking at omega-3 and also the antioxidants. That is the omega-3 and 6, and also the antioxidants into that kind. So basically, these are patients you are going to provide nutritional support. They don't, you at this point, you don't do counseling because it might not help so much. But at the first phase, you can do counseling. All right. Now, let's assume, Lynn, that our patient is okay. Lynn, yeah, I can see your hand is up. Go ahead before I give the scenario. Go ahead, Lynn.
Yeah, so I have a question. In
Yes.
the context of where they're already having cachexia and you, like an older child whose
Mhm.
parent cannot remember their last weight,
Mhm.
the usual weight. So now you might go to option
2 and
2,
3.
which is for option 2. So now in option 2 and 3, what would work for children? Because BMI of 20 is not for children. Now, in the context of children, would you consider
Okay.
moderate
Mhm.
malnutrition, or
Great. That's a
what
good
would you
question.
put in that context? Yeah.
Context. Yeah, perfect. So for now, for children, what you'll do, of course, if the children is above 5 years, then of course these are children you might consider doing the BMI for age after you've done the parameters and see where they classify. So that can also explain to you. But in a situation where now you are doing the weight for height and Z-score, that is now what can guide you. Because the good thing is, for children who are less than 5 years, it is usually the mothers or the clinic booklet can also show you the trends of how they have been gaining weight. So in a situation like that, you just do the weight for height Z-score, and where it falls, that will be able to guide you accordingly. For example, that will now tell you whether they are mild weight, or mild in terms of classification, mild malnutrition, moderate malnutrition, and severe malnutrition. And again, you can also use the MWAC to tell you. Second thing is, you can also do the strength part. If they are able to hold your hands and hold click strongly, then that means that their muscle strength is not so bad. But in most children, you find at acute phase, mostly they have muscle weakness in that scenario. So that will also guide you accordingly. If they are not able to remember the last weight in the last 6 months, then now what will help you to classify them is the aspect of doing immediately the BMI at that point, and that will able to help you define where they fall. Lynn, I don't know if that is understood.
Yeah, it is. Yeah, thank you.
Great. So now, still, I wanted to give you a scenario now that these patients come to the clinic and you are treating them as outpatients. Outpatients. So what do you do for such patients? Now, in a situation, just give me a few minutes. Just a few minutes that I get back to you. All right. Just give me a few minutes. I reply to something here which is quite urgent. Okay, so let's proceed. So I was giving a scenario where now this patient is not admitted, but they are being seen as an outpatient. Maybe they are coming for daycare chemotherapy, and these are the patients, and you find them they are fall under cachexia. Please, it is important that this patient you don't just do nutrition counseling and allow them to go home on that alone. You need also to prescribe for them the oral nutritional supplement that is going to help them. And when I'm talking about oral nutritional supplement, uh, Lillian, we are not talking about plumbinats and F75 and fortified blended flat afadhali. We are not using that for this patient. These are disease-specific cases, and therefore we need to prescribe better oral nutritional supplement. And the best in that category is Sapotan or Fresubin. You can prescribe that for them. If for children, you can look at the aspect of Pedisure and other, and even the Sapotan. There are those that are also good for children classification. I'll be able to tell you that. So please, here, if you are going to give them the fortified blended flour and the plumbinats, this is not going to have much impact on them in terms of taking care of them, because you need an anti-inflammatory marker in those products. Is that okay? I think that is well explained. So
Then,
yes.
but you find babies, kids are still being given those plumpy nuts.
Mhm.
They are being given porridges. You go to the ward, you find it is porridge. They are being given those porridges. Even if it is not the fortified one, even the homemade porridges, they will be. Yeah, you
Yeah,
still
sure.
find even some
Yeah,
are given that, and the kids on the NG tube, the porridge is being pushed down, and the baby is that's the stage.
it is done out of ignorance because one, the team is not well capacity built to know that this will not have much impact on the patient. So so it is one out of ignorance. Number two, it is done because of resource limitation. But in real sense, if we are going to take care of our patient correctly, then I can assure you then that is not going to help the patient, because in terms of energy component of those feeds, they are not enough. Okay, that's number one. Number two, they don't have an anti-inflammatory markers, and they are not disease specific. So that basically is going to cause problem to, like, not cause problem per se, but this is going to not to make much impact to those babies. We are not going to correct anything. That's why you find those patients are usually on a long-term supplementation, but there is nothing that is improving on them. So it is something that you need to really that's why we are even having this conversation, and I'm so glad that you people were able to subscribe so that we get to know the truth, because the assumption is in our facilities, the plumbinats and the what do we call it, fortified blended flour are the only things that are available, and you'll find that is what we are giving them, and even in the hospitals. But the real thing is we should not depend on that. That's why these babies end up many of times severe cases of malnutrition. They don't recover so much because we are treating them with wrong products. The product we are treating them is supposed to treat them on protein energy malnutrition, but here we are treating the disease-specific malnutrition with the product that is for protein energy malnutrition. So we might not have much impact. And it is good that we are here. So we can also go back at our different facilities and lobby, because I know the challenges we are having are budgetary constraints. But again, it is important now, like now you are technically built up or capacity built, you can discuss this aspect with the caretakers and the parent, because you'll find these babies being on a long-term care, but there's no improvement. I assure you, being that I've managed these cases for long with better products, the outcome is quite a good thing that you can show. I have many patients that have recovered so well with the better oral nutritional supplements. Thank you. Anyway, so we need to rush. Time is really going. Let's look at the last one. It's called refractory cachexia. So refractory cachexia, this is catabolic. So the patient in catabolic phase, severely wasted, no response to treatment, expected survival is less than 3 months. So these are patients who are on palliative care. You just know that they may have less than 3 months to live. For this patient, you just consider palliative nutrition support as needed to alleviate feelings of hunger and thirst. Now, I need to explain something here. For this stage, if it is possible, you can consider parenteral nutrition also at cachexia phase. You can put them on parenteral nutrition, both home-based parenteral nutrition and inpatient parenteral nutrition. That will be able to, you can do both oral nutrition supplement and parenteral or enteral nutrition feed. You also supplement with parenteral. Remember, parenteral can also be supplemented. Now, when we come to this phase, if a patient has less than 3 months to live, please don't push them so much on parenteral. We try to minimize the invasive feeding mechanism. So these are patients you can just provide something to alleviate thirst and hunger. But your main aim is not to reverse the cachexia, because at the refractory part, this is now irreversible and there's nothing much you can do about it. So you provide palliative nutrition support, and palliative nutrition support involves providing at least something that is not more energy in it, but is able to push them in a day as we wait to see how they do. But you don't anticipate them to recover that soon. I hope that is really, really important for us to learn today. Penina, is that making sense?
Yeah, I'm seeing your home screen. Go back to the slide, please.
Okay. You want to ask something? Because I wanted to present. Go ahead.
You sure you've started?
Okay, you have a question? Because I wanted to go to my other slide.
Why are you saying that nothing much can be done?
At the palliative phase?
Yeah.
Because you cannot reverse. You cannot reverse. You see, what we are saying is, of course, you see, the life is dependent on so many factors. One,
Yes.
life is dependent on your relationship with your God and any spiritual any spiritual power that you are connected to. Now, if those are things we should not put aside, and they are very important. That's why in palliative care we have the spiritual leaders and your belief system. It can change things automatically based on what you believed on. But science is now saying if you have less than 3 months to live, science has also come with a way of predicting the lifespan. So if, of course, what can determine a patient to be classified as they have less than 3 to 6 months to live, what we call survival rate, is that you could see that the treatment that they are being on is not responding. They're not responding to any type of treatment they are on currently. That's number one. Number two, they are severely wasted, and maybe their ECOG score is around 4. Yeah. So there are people that are incapacitated, and let's say also they have other comorbidities they are being managed. So most of these people are only on palliative care. All right. So if they are on palliative care and and of course they are at a refractory cachexia. Refractory cachexia means that already they have more than even 10% weight loss. They are not responding to any treatment. Then they are not feeding well. Yeah, they have so many problems. So these are patients your intention is not to reverse, because there is nothing much you can do. As I've said, you don't take away the aspect of spirituality, because that also can change the life of that patient if based on what they believed on. God can do things and they can be healed. But now this is in the context of science. Now, The reason as to why I'm teaching you about this is because I've had many cases of colleagues reaching out to me to help them on what they can do to patients who are already in the. If you do the survival calculations, they already have less than 3 to 6 months to survive, but now they want to put these patients into parenteral feeds, for example. There's nothing much that you can do to reverse the condition. And in another way, you'll still cause more pain to this because of you'll cause pain because again you are putting them into invasive procedure that is going to cause them more pain and than good, because many patients who when they reach a palliative phase, all they want is just to rest and not to be disturbed with so many bombarded with so many treatment that is not going to help them. Another challenge that we are having is many people giving their caregivers hope. Okay, so you find that chemotherapy is not working, radiation has not worked so well, and then now most of the time this is the time oncologists tend to push patients to nutritionist with an hope that nutritionists can do magic to reverse the situation. So you find many nutritionists have been left behind when the treatment started. When we were still at early phase of the disease, they never intend to refer them to nutritionist. They only send it to you now when they know that the survival rate is very low. They only want to you to do magic. And the magic here is, if you make a mistake of not being so open to the caregivers and patient and explain the case with them, they'll think if you're sending them for parenteral feeds, it's going to reverse the situation. So they do much investment, yet the patient has a few days to live. I know we cannot deny any patient health, but we need to be as sincere as possible and discuss the possible outcomes. Penina, that was my explanation. Penina, you are there?
I'm asking,
Yes.
thanks for that explanation. I'm asking, at this phase, can you still give Sapotan and Cresibin?
Yes.
What do you mean by the palliative nutrition? We can still give the feed to.
Yes, you can still put
least.
them, but not with an intention of doing a reversal. But what you are providing is for them just to live, to sort the thirst, to sort the aspect of hunger, and and just to make them comfortable. But your main goal is not to cure or to reverse the cachexia, but you are doing that basically to extend a little bit of their days so that they don't go into hypoglycemia. So you can still give that, yes.
Okay, thank you.
Welcome. Thank you, Mr. Nyariki, for joining. We are still continuing. So now that we have looked at the 3 stages of cancer cachexia and it has been well explained, I think we need to go with speed with the few minutes that we have and see how much we can cover. This series is usually very interesting, and sometimes 2 days might not be adequate to capture everything, but we are trusting God that we are learning. So basically, this is the summary of what I was explaining in stages of cancer cachexia. So we have pre-cachexia. It is characterized with the systemic inflammation, weight loss less than 5%. So this is the stage where we said you provide nutritional counseling, you can provide fortified blended products and oral nutritional supplement, which has anti-inflammatory in them. Then, of course, this is now the cachexia phase. So they is characterized by systemic inflammation, weight loss more than 5%, or more than 2% in sarcopenia, or body mass index of less than 20 kg per meter square. So in this case, you have loss of cell mass, that is body weight and muscle mass is characterized at that phase. Then, of course, the last one is advanced cachexia, or what we call refractory cachexia. It is characterized by advanced cancer refractory to anti-cancer treatment. Expected survival is less than 3 months. And so you can just provide end-of-life support. And the ultimate goal when we are talking about, so you see patients starting from normal here, but they end up dying if we don't intervene at any stage, especially stage 1 or stage 2. So you find death. So this is basically what the stages of cancer cachexia are. So anytime you see a cancer patient, you can either meet them at any phase. Yeah. So when you meet them at any phase, Mary, then you now know what to do. so that you don't just manage them blindly. I've given you the criteria of management that if you meet them here, you know what to do. If you meet them here, you know what to do. If you meet them here, you know what to do. Our main aim is not is if you meet them at stage 1 at pre-cachexia, please do as much as you can so they don't fall into cachexia phase, because you find many people, many patients who are just stable. They are walking, they are coming to do their chemo, but because nutritionists are not able to intervene for them early or provide for them adequate care, they end up moving from precachexia to cachexia. And you know, some of these things do happen when you cannot see by your own eye. You need to go deeper and investigate. Yeah. So that is basically how to manage our patients. I don't know if you have a question on that before we move on the staging part. I wanted us to go to the next phase. That is now on the diagnosis. Is there anybody with a burning question, or we are good to go? Chetna, are we okay? Are you following? Okay, great. So let's look at now, how do we diagnose it? Now that we've already, of course, staging and diagnosis, they are not more or less the same. But I want to teach you something that is very interesting to learn. I know this one you might have learned it somewhere, or maybe you have not learned it before. So now, this slide we are talking about is not only applicable to cancer cachexia alone, but any patient who you are managing for any disease, or any patients you are managing for cancer itself. Now, the first step is usually to do a nutritional screening, and we have several validated tools to conduct a nutritional screening. One of them, of course, the easiest one is what we call a nutritional risk screening tool, and I hope by now you've known these tools. If you don't have them, kindly after the class you can reach out so I can take you, I can give you some to in your wards for your care. So remember, it is nutritional screening tools, not assessment. Assessment is in depth, but screening is just to get a quick questions. There are several tools that we can use for nutritional screening. Example is what we call malnutrition universal screening tool, MUST. We have nutrition screening, risk screening 2002. We have short nutrition assessment questionnaire, and we have malnutrition screening tool. So all those tools are for screening. After you've done your screening, then you go to the next phase where now you do in-depth patient assessment. So assessment, the best tool to use for cancer patient is what we call patient-generated subjective global assessment tool. So this is a very comprehensive tool. I might not be able to get time now to really go deeper into it, but it is one of the best tool to use for your patients. So now, for you to diagnose cancer cachexia effectively, all you need to do is just do the initial screening. You can even do the BMI, body mass index, that can help you, and even 24-hour that recall that can help you if you don't have those tools. Now, the next part is now the diagnostics assessment. So this is when you do in-depth assessment. So in-depth assessment, we have what we call phenotypic and etiological. So phenotypic is where we have weight loss. So this is where you ask a question of the previous weight loss. They have low body mass index and they have reduced muscle mass. So these are the three phenotypic assessment that you need to ask. So for example, if I was 70 kg in the last 3 to 6 months, then when you are meeting me for the first time, you find my weight to be, let's say 65, and I'm not in any weight control program, then I might have lost more than 5% of my weight in the last 3 to 6 months, unintentional weight loss. Therefore, I've met the that is what it means. Then, of course, low body mass index. The normal body mass index is between 18.5 to 24.9. So if you find my body mass index is low, let's say, for example, maybe less than 18.5, then that is a qualification. Then we have reduced muscle mass, and I've explained this. So this is where we use the muscle strength to know where the patient falls. So that can happen through them squeezing you, or they can use what we call hand gripe. Hand gripe is just a tool to check the muscle strength. Yeah. Then etiological is reduced food intake or assimilation disease burden, stroke inflammatory condition. So etiological here we can talk about if the patient has not eaten for more than, let's say, 5 days, they fall under etiological. If you do the CRP, it is elevated, that is basically inflammatory condition. Or if they have any disease burden, it is etiological. So when you are doing your diagnosis now, these are the requirements. So meets criteria for malnutrition diagnosis is if require at least one phenotypic criteria and one etiological criteria. So what it means, any patient who comes to you with weight loss and reduced food intake, classified, those patients are already malnourished. You don't even need to think twice. Or they come with the CRPs are elevated. It doesn't matter whether they have cancer or not, but when C-reactive protein are high and they also have reduced muscle mass in terms of muscle strength, they are already met the criteria. Then now for severity grading, if now you want to know the severity, severity determined based on phenotypic criteria. So you'll know if it is weight loss, is it more than 5% in the last 3 to 6 months, or BMI of let's say less than 20 kg per meter square with more than 2% weight loss. So that will tell you the severity. Even the reduced muscle mass, you know the severe. There are those patients who will be able to hold your hand and squeeze completely, but there are those patients who will not have that capacity. So that's when you do the ECOG score. Did I make sense on that? Joseph Koini?
Yes, I'm following. It is
Mhm.
really flowing. I'm digesting slowly.
Ah, great. Mhm. That's okay. So basically, I wanted to teach you about this. So you know, Kadomi, Lillian, have you been able to interact with this phenotypic and etiological criteria for diagnosis?
No, not yet. I haven't.
Great. So it is now high time now you have it. This is now how we do the diagnosis of malnutrition for not only for cancer patients, but even for patients who are sick and admitted with that. So when you are doing your weight, height, BMI, and MWAC and Z-score, all you need to check is also the phenotypic and etiological to classify those patients where they fall. This will help you in terms of intervention. Time is not on our side. Now, so probability here of survival, remember we've talked about less than 6 months survival and all that. Now, if more than a few 3 to 6 months to survive, then regular screening and nutritional intervention if and when required. So these are patients you'll not be able to expose in so much screening if they have less than 6 months of survival. So you'll not be exposing them to to monthly nutritional assessment or weight assessment. Yeah, no, if they have more, sorry, you can do even monthly assessment. That, yeah, if they have less than a few, that is a few months, that is 3 to 6, decrease invasive of nutritional intervention. So Penina, this is what I was talking about. If they have less than 3 to 6 months to survive, then you don't need to put them on parenteral feeds because you are going to cause more harm to them. Then preference of counseling and oral nutritional supplement is recommended. So even Fresobin, Sapotan is good, you can give here. Then less than a few weeks now, comfort directed care, relieve eating related distress and thirst if present. So here is just you try to manage few things. You can, if they have constipation, that is what you sort out. You can just provide them with, if they cannot take, they can take 2 to 3 spoons of food. You support them on that. You provide comfort for comfort care because they have less than few weeks to survive. I know this is very painful topic to discuss because our intentions as healthcare workers is not to lose anybody. But again, as I've said, that spirituality plays a big role here because God can reverse any condition that the patient has. So if their faith is strong and we have closer spiritual support, this patient can change. Their case can change completely. And we've seen those changing. Remember, this is science, so we are not trying to take away the spirituality part. Spirituality is supreme to science. So, but now in science, this is what we have. The reason as to why we are doing this is just to try to support the patient, the caregivers of patient, because we've seen a scenario where now, yes, as a healthcare providers, many a times you find that the eyes is on you to provide direction, and sometimes you can give patients patient relative false hope. Then they start blaming you that, doctor, you had said that we are going to do well. Of course, yes, we don't have to negatively confess about the case, but these are scenarios you need to discuss with the patient caretakers so that they be aware of what we are looking into. Now, in terms of nutritional intervention, we are there now. So factors related to patient. So these are things that factors related to patient. This flowchart will be able to help us. Local effects of tumor and treatment. So we are looking at the nutritional impact symptoms, physical inactivity, side effects of anti-cancer treatment, and psychological situation stroke age. So these are things that you need to check. So nutritional impact symptoms could be nausea, vomiting, diarrhea, and all that. Physical inactivity, if the ECOG score is less than 4, for example, or is at 4 or 3. Then side effects of anti-cancer treatment, like we talked yesterday about mucositis, we talked about stomatitis, gastritis. Could be also, we can have polydipsia. These are side effects of treatment of chemo and radio. Then if there's a psychosocial situation is low. So this could lead to weight loss in cancer. Then again, we have factors related to tumor-induced cachexia pathophysiology. This is one we learned yesterday. So this can be systemic inflammation. This systemic inflammation could be secondary to cytokinins that we had discussed. Endocrine dysfunction, we've looked at the hormonal component in terms of cancer cachexia. And yesterday, we were able also to look at altered metabolism. So this, in real sense, is going to have changes in appetite, taste, and smell, changes in gastrointestinal tract motility, reduced muscle function and mass, reduced fat mass. All this is going to have weight loss. So this is how many cancer patients tend to lose weight. They have what we call patient-related factors, and then we have tumor-related factors. So all this will definitely lead to weight loss in cancer patients, and this is what also has the consequences of causing cancer cachexia. So this flowchart is very important for you to know when you are talking about cancer cachexia. So if we are looking at the management, this flowchart also help us now. So there are questions you need to ask yourself. I'm almost winding up. So the first one is the patient expected to live for at least a few, that is 3 to 6 months? This is the number one question, the entry point. If it is yes, then you need to perform regular screening for nutritional risk. So these are the tools that I was talking about that you need to do. Or if you want to do a comprehensive assessment, you use what you call PGSGA. So it is patient-generated subjective global assessment tool. It is quite subjective tool to use. So then the next step is the patient at nutritional risk. If you've done this and they are at nutritional risk and it is yes, then you perform a comprehensive assessment, which involves nutritional status, metabolic status, functional status, nutrition impact tools. I think we could do this practical someday. I'll have a makeup class one day. Remind me so that we can do a case study to help you understand this. So if the patient is nutritional risk, you have to go further and do this check. So if yes, then start a tailored intervention. So individualized nutritional intervention by a nutritionally trained professional team, alleviation stroke treatment of nutrition impact symptoms, psychological social support, supervised, physical exercise, strength, endurance, consider anti-cancer treatment. So this also is depending where they fall. So now in question 1, no, the answer to question 1 is no. Is the patient and or the family members experiencing eating related distress? If the patient is experiencing or the family members are experiencing eating related distress, then nutritional advice, education about cachexia, treat symptoms, offer psychological and palliative support. So if they are not experiencing it, then reassess at weekly intervals. So these are patients you need to review weekly. Then is the patient at risk? If the patient is not at risk, is the patient planned for anti-cancer treatment with high risk of inducing malnutrition? So these are patients when you first meet them, they are not at risk based on this assessment, but they are going to start chemotherapy or radiation therapy, which is targeted for treatment. If that is the case, then consider a preventative prophylactic supportive approach. So when you talk about prophylactic support, for example, yesterday, you remember me saying, and I think Lillian had asked this question for children who are going through radiation therapy to be their cases going faster than expected. So for that case, what we do, you insert gastrostomy tube before they start the treatment, because this will help in feeding. All right. So that is what we mean by preventative or prophylactic support. The surgeons know, and the multidisciplinary team know. I hope after this training, you are going to join the multidisciplinary team, the tumor board of your facility. If it is no, then reassess at least every 3 months. If they are not going to start any intense treatment, then just reassess those patients after 3 months. So basically, this is how we do the flowchart for care. I might not go through these strategies because I'll share the notes. This is my last slide, then we end it. Now, how do we manage our patients? These are the calculations we do. So 25 to 30 kcal per kg is what you start with as the maintenance. And then, of course, now this is for adults. For children, I know Lillian is about to ask me the next question. What about my babies? Because I know she is a mama babies. Lillian, don't worry. I'll be able to share with you guidelines for children. And by the congratulations. So team, help me also appreciate Lillian. She won the Nutritionist of the Year award for in terms of child care. Congratulations, Lillian. You're doing a
Thank
good job.
you.
Yeah, and so I'm so glad that you make it. I also, in the beginning of the year, I was also nominated the Distinguished Nutritionist of the Year in Kenya 2025-2026. Yeah, but now I'm so glad that in the pediatric space, you're doing such a good job. So just to wind up, so these are the how do you do your calculation. So if the patient is malnourished or high stress, treatment such as bone marrow transplant, you'll start at 30 to 35. Then severely depleted or hypermetabolic, then you can start at 35 to 45 kcal. I need to put a rider. There's something called refeeding syndrome. So basically, this occurs when somebody has not fed for more than 5 days and they have come to your place you are seeing them for the first time, and they have been reported that this patient have not been eating. You don't start with the higher calories. They'll have a refeeding syndrome. So that's why we are said this is maintenance. So here you'll start even at 20 to 25 kcal per body weight. So that is energy. For proteins, 0.8 to 1 gram per kg is recommended dietary allowance for adults. Then if you do 1.0 to 1.5, most patients with cancer adjust for visceral protein status and albumin level. So based on their albumin findings, then you can increase. Then 1.5 grams per kg bone marrow transplant recipients, 1.5 to 2 severely depleted patients with cancer. Majority of my patients usually fall at this 1.5 to 2 grams of protein. Then for fluid intake, you can either do the recommended dietary allowance based, or you can do the 30 to 35 ml per kg. So this is basically how we do the calculations for care. Do I need to go through this? Yeah. I think time has gone, but I'll be able to share the screen. I've said we can have a makeup class one time, maybe next week. We can have free still. If we have time, you can propose the time that we can do to have for us to have the clinic. So yeah, this is my contact for those who don't have my number. This is my email address. My clinic is the Kenya Medical Association Center, Upper Hill, 7th floor, suite 740, or you can also find me at a clinic at William Sword House, 2nd floor. Mostly weekends, that is when you'll find me on booking basis. So you need to call, so we book you. So I operate in those two clinics in Ngong Road. So the Williamson is at 4th Ngong Avenue, while KMS Center is at Upper Hill. So that is where I'm doing my consultancy services. Thank you very, very much. I open up for questions, clarifications, additions, subtractions before we close the class. Chetna, start, then Lillian.
Okay, me? Oh,
Chetna,
I was asking.
Yes,
If you are
yes, go
going to
ahead.
share the notes with us and the recording.
I must, like I did yesterday. Were you
Okay.
able to get yesterday's recording?
You sent in the email.
In the WhatsApp group, by the way, are you in the WhatsApp group, Lillian? You know that you've just reminded me.
I
Let me.
don't think so.
You don't
Am
think so? Let me
I?
just add you now. Let me add you. Sorry about that. I don't know why I forgot to.
I'm in the Cancer Cachexia group. Is that where
Yes,
you shared?
yes, yes. That is where I shared. Yesterday I shared the recording and slides.
Slide? No, I haven't found the slides. The recording, I found it. Even no, I haven't seen those.
What do you mean? And I can see them here. Let me reply here.
Oh,
Here.
I have seen the recording.
Yes.
Okay. Yeah, I hadn't read them. Okay, sawa. Thank you.
Yeah. So those aren't for yesterday, but today also I'll share the same.
Okay.
Okay. Thank you. Chetna, do you have a question?
Yes, doc.
Yes.
Yeah, you see, in case if like in my facility, there was a patient today
Mm-hmm.
whose all the reports were okay,
Mm-hmm.
and only CRP was elevated. So
Okay.
what can be the reason?
Yes. So when CRP is high, that tells you that patient is going through severe systemic inflammatory response syndrome. It's just a matter of time before those parameters start going down. So those are patients you need to start intervening because already we have inflammatory process going on, and then you need to start intervening so well. So meaning you need to increase her proteins because they are already going through negative nitrogen balance. It's just a matter of time before those values start coming down. So you need really to prevent the infection. So put them on, those are patients you need to put on antioxidants as a supplement. Number two, you need to increase their protein intake because they are already going through catabolic process. So any moment CRP you see is high or elevated, please intervene without thinking twice whether other parameters are normal.
Does this mean that the patient has cancer?
No. It doesn't mean they have cancer. You know, CRP is just a marker of checking for any ongoing infection. For instance, if God forbid, maybe I am having fever, if we do my CRP is elevated, it doesn't mean I have cancer. Already I'm going through infection. So if I'm not intervened at early phase, and then the fever persists and maybe translate to other things like maybe pneumonia, then means that I'll not be able to eat adequately. So if you're not able to intervene early with the CRP report, then my body is trying to fight infection. But if I'm not eating enough, then I'm at risk of becoming malnourished. So CRP does not only apply to cancer patients alone, but generally to all patients who have severe infection or acute infection phase.
But doc, she was very much normal.
Yes,
She
she was very
didn't.
much normal. The
She
reason
didn't
I'm
have.
telling you that their physiological state is changing. If the CRP, as you've described, was elevated, you see what happens
It was
if
14 point something.
yeah, it's not quite higher. It is not so high. But again, the moment CRP is going high, is more than issue is not normal, then that is a patient you need to intervene and monitor them. Yes, you might not be aggressively in terms of taking care of them, but just be cautious and put them on a proper nutritional intervention. Because if they're still doing more investigation and the CRP is still elevated, then it is possible that even the feeding is not proper. So you need really to intervene better and provide them. What you need to do is never for those patients to go into negative nitrogen balance. That one is what you try to avoid, either by providing adequate calories or providing maximum proteins to prevent them from going into negative nitrogen balance. Chetna, is that okay?
Yes, doc. The only thing is that she seemed to be very much normal. She was very much normal. She had
Mm-hmm.
just she was referred to me by a doctor for to
Mm-hmm.
manage dyslipidemia and obesity.
Exactly. So you see now they already have a risk factor like obesity. They have obesity and then they have CRP which is elevated, meaning those are the patients who are at risk of cardiometabolic conditions like maybe diabetes, hypertension, and everything. So it's better you manage you in any patient, whether obese or not, when they have elevated CRP, it means that they are already going through systemic inflammatory process. So your work is to make sure that you stabilize that patient by providing adequate proteins so that they don't go into a catabolic phase. Okay, so after that is when now, after they have recovered and the CRP has stabilized, then now you can start managing the obesity and other dyslipidemia already. Is that making sense, Chetna?
Okay, doc. Thanks.
So just provide adequate proteins. Calorie you can restrict, but make sure you have adequate protein for that patient.
Okay, doc.
Thank you.
So I can prescribe complex carbs and proteins like a high protein intake, yeah?
Exactly. Just provide complex. In fact, you can even go as low as 45% of the total calories or even 40%, but make sure that the proteins you maximize.
Okay.
Okay, thank you.
Thank
Any
you.
other person with a question? Mary, today you don't have a question. Penina, Lynn, I'm looking forward to your questions today. I want to end the session. You have 2 minutes for us to end this. I hope you people have learned something within these 2 days. Yeah, I know time was limited, but I think learning has taken place. Joseph, anything to add to question? Okay. Mary?
Okay, Joseph.
Yes, Joseph, go ahead.
Yeah, I think this is just a concern. I
Mhm.
was just brainstorming in this
Yeah.
case of Cachexia. Now, for instance, maybe you get a patient with no limbs, that is,
Mhm.
that we are not able to take the BMI
Okay.
because of it. They are being bedridden or they don't have limbs.
Okay.
So, in which aspect are you going to categorize them? That those they are with the 5% or above 85%. Are you going to use the other parameters like demiquet?
Mhm.
Yeah, that's just my
Mhm.
concern. I was just brainstorming on that.
Great. Definitely. Just give me a few minutes. I'll do. Okay. Yes. Of course, you have to use that. Which one? I'm just trying to show you something here. Mhm. So in those patients who are bedridden and you're not able to get there, they cannot stand on a weighing scale and all that. Oh, we have solution for everything. Joseph, let me tell you. Let me just show you what to do for those patients, for amputees and everything. Yeah, I know time might be short for me to do the explanation, but this is what we do for those patients. Where is it? Trying to project my screen so that I can help Joseph answer the question that he's having. All right, so Joseph, we have a malnutrition universal screening tool. It has given us very good steps. What to do for amputees. This is very nice booklet. And I know, Mary, you don't have it, but don't ask me to send for you. I know. Chetna, I know you don't have this.
Please be with us in the WhatsApp group.
I know you people will always bombard me with how to do this. Anyway, this is learning, and my role as some Okinda is just to make sure that I capacity build your team. All right, so Joseph, just to answer your question, if we have those patients who are amputees, this is how we calculate their body weight. So if it is below knee amputation, is the current weight in kg times 1.063. Full leg current weight times 1.18. Forearm, this is how we do calculate. Full arm, this is how we do calculate. For those patients who are identified as being overweight or obese and are acutely ill, the need to address weight loss should be postponed. Chetna, this is what I was telling you, until that individual is more stable clinical position. So you are saying that they are okay, but their CRP is high. The moment that their CRP is high, they are at acute phase, acutely ill. Chetna, that is what I was telling you. You postponed weight loss, sort them out. Yeah. So Joseph, what we do for those patients that are bedridden and you want to take their weight, there are always a way out. Either you can use MWAC for adult or you can use the demispan. So the demispan is here, as you've said, it will be able to help you know. So demispan is able to know, you can get the height you can measure with the tape measure, and then you know where they fall in terms of the age, and that will definitely help you in estimating. So once you've gotten the height, then you can know where they fall. And then, of course, with that in place, then we can always get the height from here to here using the tape measure. And then with that, you can be able to calculate the other parameters. So demispan can be able to assist you. And even estimating height from knee height is there. So Joseph, I think this book will be able to answer your question if I don't take much time explaining it, but I'll share in the group so it can assist you.
This is the BIPEN booklet manual.
Yes, you have it.
I think I have it.
Perfect. So that can really help to answer your question, unless maybe I didn't get it correctly.
Okay.
Yeah, but it can always help to answer your question. Hey, we need to end this class now, team.
So, just a moment. I just wanted to ask you.
Yeah.
This patient who is obese and whose CRP is elevated, still we can recommend physical activity to lose weight.
Yes, you need to. You can recommend physical activity for them because that also is going to help them. When they do physical activity, then you are going to reduce the amount of the fight and fight hormones, the cortisol hormones. So that is going to boost the immunity. Physical activity has been proven to boost the immunity of patients. So it can help. Yes, if they are able to do, especially not so intense, because if you do intense and the CRP is quite elevated, then that is a challenge. You need just to do moderate physical activity as they recover. And then put them on antioxidants too. So don't forget about that.
Okay, Doc.
So,
I have another question. Just one
yes.
question.
Yeah.
Yeah. Now, there was a research done by a scientist. Yoshinori Osumi of Japan, who has won a Nobel Prize. Yeah, so now, as per his research, intermittent fasting is helping to fight cancer or to prevent cancer. Is that true?
Yes, it is true.
How?
And I think I'd explained this yesterday, but yeah, go ahead. You want to know
No,
how?
Doc. I think, yeah, I missed that. Maybe I have not understood. Can you explain it in
All
briefly?
right. So this is applicable for type, if they are confirmed cancer, it is type 1 and type 2. These are patients that has a higher survival rate. So you can put them on intermittent fasting. Basically, what intermittent fasting does is that you are going to produce more ketones, which cancer cells are not able to utilize. Remember, we said that cancer cells have ability to take glucose from, that is blood glucose. Okay, so when you're doing intermittent fasting, it means that you are depriving the body calories, and therefore the body is going to resort to break down fats to produce energy. The byproduct of fat metabolism is ketones. So cancer cells have they don't know how to use ketones in its own form. So that is why it is recommended, especially stage 1 and stage 2 cancer. For stage 3, stage 4, please don't put them on intermittent fasting because already it is a spread disease. It is not going to help. So for those patients, you just allow them to eat everything they can eat. Don't restrict them in terms of calories. Metastatic disease, don't put them on intermittent fasting. It doesn't have much impact. But for early stage disease, yes, it will have a better outcome. But also you need to be monitored. It needs to be under healthcare guidance, not just like that.
But doc, type 1 and type 2, they already have loss of appetite. Then still we need to reduce the carbs.
No, you see now what happens is you need to stabilize them first. If there's type 1 and type 2 and they are not critically ill, or then those are the patients who qualify. But you don't put patients who are critically ill with elevated parameters of blood work into intermittent fasting. You're not going to help them, yet they need to eat adequately.
So we can prescribe them a small portion of complex carb and more of protein and fat.
Increase
That's what.
proteins, yeah. But you need to be very well guided. Such patient, I prefer if you have a case like you want to introduce, we can have a case and we discuss. We can have a multidisciplinary discussion. We look at every parameter before you initiate it kindly. Because sometimes those information can mislead patients. You need to trend very, very careful.
So what sort of parameters we have to take care of?
Blood works must be okay. The kidneys must be functioning so well. The liver must be in a good state. The patient should be not having any related severe illness. Yeah. So if it is a cancer, we've already diagnosed the patient is stable, and we can discuss with them that part. And of course, the patient must agree. Yeah, you don't just start if they have not agreed to the intermittent fasting, because some patients will not be able to agree on that.
Good of thanks, you have answered. Thank you.
Thank you. Odero, I saw your hands up. I don't know if I got it right. Or you wanted to ask?
Yeah, I wanted to ask the part in this document that you're showing on the screen right now, the part that is showing about the weights, how to calculate the weights of amputees, yeah? Does it also apply for children?
Yes. It can also apply for children. It's a standard. It's a universal tool.
Okay, and then so now because of refeeding syndrome, when I work in a pediatric ward, we have oncology patients. So sometimes when they come in, they are severely malnourished and the intake has been really low. So normally, because of the fear of refeeding syndrome, we normally start them off with F75, and then we proceed to F100 sometimes. However, what is noticeable is that the progress is really slow, actually, if you use F75 and F100 trying to, so now I think today now I fully understood. Thank you for that part.
Great. Thank you. I know sometimes the challenge we are having is just in a resource limitation. But if you can put these patients, like these babies, on Pediasure, you can get Sapotan. They can pick up very fast. They can pick F75, F100 are good, yes, but really, they might not do much to the patient.
Yeah, it takes a while. But but now with the fear of refeeding syndrome, wouldn't F25 still be a good choice? At least until...
Yeah, of course you can start, but you remember what we talked about yesterday. These patients, they are not having any challenges with their organs.
Okay.
You remember the visceral fat is intact, so meaning their liver might be functioning well, but yet they're having the challenge. When you look at protein energy malnutrition, they're having what you call reductive adaptase, where you need to trigger part the organs to work. But now for these patients, their organs could be working very well, but they are having that severe wasting. And that's why you see they take time to recover, because the aspect of F75 initiation is just to kickstart the function of the normal liver functions and other organs to trigger them. Now the metabolic process goes back to normal. But in this scenario, you'll find maybe the liver is not massively affected. So you could, yes, they could be having refeeding. You start at a low calorie, just to avoid any complications that could arise from refeeding syndrome, like hyperphosphatemia and all that. Physiologically, they are unstable, but it doesn't mean that their organs are really deeply affected. That's why you'll find even our cancer patients who has passed on, their liver could be still in a very better state if it was not messed to the liver. But now, when you look at that with a person who has died due to starvation, protein energy malnutrition, their liver will be really functional.
Right. Thank you.
Thank you. Lydia Simi, I hope your question is the last one. Then we close this class. People need to go and
Just
rest.
one last question.
Yeah, there's a
Okay.
Lydia, then Chitno. Lydia?
Okay, Mr. Kinda, a quick one. I
Yeah.
wanted you to comment on whey protein. I
Yeah.
have this patient with colon cancer that is in stage 3 on chemotherapy, the 3rd round today.
Yes.
And they had a relative who was supporting them very much, and the relative had so many tins of whey protein that
Yes.
they brought around. So
Yes.
I was doing some research, and they told me first, before they initiate the whey product, the whey protein, we do the RFTs. RFTs were okay; they are very normal. The mate hasn't touched the organs. It's only the lymph nodes. Lymph nodes are the ones that are affected. So
Yeah.
I was asking you comment about it because the patient today has lost 2 kgs. And I'm starting to get worried. Has a normal weight, but there is weight loss. 78 kgs with 1.68 meters square. So meaning the patient is on, I can say, a little bit overweight, but still there is an indicator of weight loss. You can comment on it if you have time.
Yes. So that's a good question anyway. So whey protein is very important, especially for cancer patients, because it is synthesized in the muscles, not in the liver. What it does is that its synthesis in the muscles help it to build up the muscles that are wasting. So that's why you find even most of these nutritional products that I'm recommending, they are made from whey protein. So if you have a patient who has cancer and either they mets to the liver and the liver functions are really deranged, then you can recommend to them the whey proteins. The whey proteins is synthesized in the liver, like for example, yogurt. It has been well broken down. If you give them, it means that the whey protein are synthesized within the muscles. So you'll find that the liver will be allowed to rest. So I totally recommend it that you can give them, they can be put on whey proteins because again, you are so sure they are going to be synthesized within the muscles and they're going to support the muscle build-up, muscle mass.
And again, again, if I can add, I will consult you to guide me on how I'm going to go about it with the amounts. I don't know how to prescribe those powders.
Oh, okay. Yeah, that one we can side chat.
Okay.
Oh, thank you. Chetna?
Yes, Doc, last question about the same patient. Now, I should give that patient protein 0.8 to 1 as per the body weight, or 1 or 1.5. How should I calculate a protein then?
All right. So this is a patient who is obese and having elevated CRP. So meaning
yeah, other conditions are okay. Vitamin D was low. Only vitamin D was low. All other functions were okay.
All right.
Like all parameters.
Yeah. So protein, you can do 1.2 to 1.5.
1.2 to 1.5, right?
Yes. Because you see, they are already having they are already now, Chetna, there's something called adjusted body weight. I don't know if you have learned about it for obese patients. I hope not. But anyway, just do 1.5 to 1.5 of their usual weight, because if we do the adjusted body weight right now, it might give a challenge for you because they're still in infection state. Once they have recovered, then you can bring it down to the adjusted body weight. So 1.2 to 1.5 will be okay for that patient.
And calories, 20 to
calories,
25?
you can do 20 to 25.
Okay.
Yeah.
Thank you, doctor. Thanks a lot.
Karibu. All right.
If
Guys,
I
you
forget,
have some. Yes.
you
Yeah.
maybe you could
Mhm.
give us also the requirements for children, the calories and protein requirements for children.
Perfect. That one, consider it done. I'll share in the
All
group.
right.
You
Thank
and Lillian, I know you are your babies team, so I'll have to take care of you too. All right. Thank you, guys. I think we end it there. It was quite an interesting. I hope you can leave a comment in the WhatsApp group how the classes were, or in the chat here before we end. Then I'll be glad to see your comment on what, if there's any area we need to improve on, we can do that next time. I hope also you'll join our next series. I think next series we really need to tackle so much on nutrition assessment for cancer patients. It is an area I've overlooked, but it is important and it is a big one. And I want to thank you all for joining today. Still, we can all have the series going on, the questions and answer in the chat box, in the WhatsApp group, so that you will learn. Learning is usually a continual process. So we need to have another class as Chetna had proposed. Otherwise, thank you very much for joining. Mr. Nyariki, did you learn something? I know you joined late today.
My apologies, but yes, I've learned something. There is a lot to look into when you're checking on nutrition issues.
Exactly. All right. Thank you very much. And I think, team, we end it there. And we meet again when we have time. Thank you for joining. I hope it was a good session. Goodbye. Till next time.
Goodbye.